All right, Daryl.
Hello.
Still good to go?
Oh, sure, why not?
Okay. So we still have a few more minutes before we'll get started, but just wanted to make sure you were still good to go.
Sure.
Okay.
I finished my presentation.
You did. Good. Nick of time, right?
I actually just had to put some tweaks in it, update it, make it especially snazzy.
Good.
Is my video back on?
It is.
Okay.
It is. Yep, it's working just fine.
How many people have signed in thus far?
So we have 2 others. Yeah. Okay, so it's 1 o'clock, so we'll go ahead and get started. So welcome, folks, to Thursday Dairy Update. I'm Kathy Barrett with the Cornell PRODAIRY program, and along with Dairy Business Communications, we have been offering this weekly webinar every Thursday from 1 to 2 p.m. to kind of get out into the field some of the new research that's going on on campus and elsewhere, as well as some new information that's got practical farm application. And so today's webinar is going to focus on clinical mastitis treatment decisions and using pathogen ID. And fortunately for us, Dr. Daryl Van Nydam is going to be our presenter for today. So I think most of you probably are aware who Daryl is, but he's a professor at the vet school and at the animal science department, director of the Quality Milk Production Services, a DVM, and has done a lot of work in this area. Before I pass the ball over to Daryl, I just wanted to let you folks know that we are recording this webinar, so if anytime you want to access it in the future, it should be on our website in the next week or so. And because we're a small group, if you have any questions, feel free to just unmute yourself and kind of butt into Daryl. He can't see you to know that you're looking to ask a question, so feel free to be a little bit pushy and kind of butt in and say you have a question. And if you're not comfortable doing that, go ahead and use the chat box. Either way, we're free to be able to answer your questions that way. So Daryl, I'm going to go ahead and pass the ball to you so that you can start your presentation. So folks, there'll be a little bit of a screen change here.
All right. Does that work there, Kathy?
Not yet. I can see your face, but not your PowerPoint.
Do anything different? I did. It's on my screen right now.
Okay, and you hit share your screen in WebEx?
I never undid it.
So it should have just popped right up.
Monitor one. Let me try again.
Sure. Oh, there we are.
Yeah, we're good?
Yeah, got it.
Perfect. And where will I see these people if they want to ask a question?
So what they'll do is they'll unmute themselves until you'll hear them. Very likely they don't have video cameras, so you won't see their faces, but you'll just hear them. You'll just, similar to what I'm doing right now. Or if they have a question and they put it in the chat box, for just a few seconds, the chat box will show up on your screen.
All right, cool.
So if you don't see the chat box come up, that means that there wasn't a question typed in, okay? All right. So I'm going to go ahead and turn off my video and mute myself, and we'll let Daryl take it from here.
Thank you, Kathy.
Sure.
All right. So I'm still here, so I'll get going. But please, how many of you are out there, if there are any, feel free to use a little chat box that Kathy mentioned, or unmute yourself and speak up. It's way more fun for me, and I think a lot more informative for everyone who's listening in if there are questions from the participants rather than just listening to me yammer on and yammer on. Or if you don't want to do that, feel free to shoot me an email sometime thereafter, and what else at QMPS, and we can hopefully answer your questions. My email is right here, so grab that if you need to, or you can just Google me. All right, so like Kathy said, we're going to talk about clinical mastitis, and particularly treatment decisions based on pathogen identification. So first thing, so we don't get our shorts all in knots, treating cows with clinical mastitis can't possibly be that confusing because the list of things that we get to treat cows with is really small. You know, if we count these guys up here, there's really only 6 or 7, of which really only 6 you really find on dairies. And this group right here, they're all essentially the same drug class. They're all penicillin-based beta-lactam drugs. Pyridomycin pursues is a little different, but not much. And but these are pretty much the same. So we can't get too serious about choosing which two. So we're going to move right on beyond that, and we'll perhaps come back to that if there are other questions. But just if you don't know, Quality Milk Production Services operates 4 labs in New York. We've got one up here in northern New York in Canton, one here in eastern New York in Cobleskill. I'm sitting here in the central lab in Ithaca at Cornell, and our western lab just recently moved from Geneseo to Warsaw, so maybe that's some new news for some of you. Okay. So, why is QMPS working on pathogen-based treatment decisions for clinical mastitis? And if this were a more interaction lecture, interactive, I'd ask for this. We'd raise hands, have some chatting, but I'll just blaze through it. What we want to do in the dairy industry, it all comes down to making more money, while of course not compromising cows' health. So how do we make more money? By pathogen-based treatments for clinical mastitis. If we know which pathogens are causing the mastitis, we can save money on treatment tubes and labor. We can decrease the risk of residues in the tank. So if we treat less cows, or at least treat judiciously, they'll have less risk of antimicrobial residues in the tank. And then there's always the boogeyman, which often takes the form of government, and that would be someone telling us we have to. And I think sometime in the future, it will come to pass in the United States, it has in many other countries, that we can't indiscriminately use antibiotics. We have to have a good reason for doing so, and knowing what bacteria is causing mastitis is one of those things. And part of that reason is some people believe this might decrease the risk of antimicrobial resistance. And in doing all this, we can actually sell more milk. So hopefully these things will become apparent by the end of this presentation about how they work and how you might want to do them. So why might this work? The main thing is that not all cases of clinical mastitis should or need to be treated. We'll start right in with 85% of clinical cases are mild or moderate. And what do I mean by mild or moderate? So we'll call that mild severity score, clinical score 1, and that's just abnormal milk. The rest of the cow and her udder is fine. Moderate or severity score 2 means that the cow is otherwise healthy, but her udder might be inflamed and she has abnormal milk. It's those 15% of cases that we all remember, right? I remember I'm a clinical veterinarian, so if I do see a cow with mastitis, it's often one of these 15% of the cases where the cow is also sick, so clinical score 3, and that means she's probably off feed, has decreased rumination, she's probably got a fever. But if we look at large data sets, that really only represents about 15% of cases. And those cases should be treated immediately and systemically, at least with fluids and perhaps intramuscular antibiotics like some ceftiofur product or some ampicillin product. However, for these other majority of the cases, 85% of cases, those mild and moderate ones, delaying the treatment for 26 or even 36 to 48 hours doesn't change the outcome, and they don't need systemic treatment. In fact, we're just probably overusing antibiotics, wasting money, increasing risk of residues and stuff if we put systemic antibiotics in those cows. So here is data from 622 cases across 52 different dairy farms in Wisconsin. And if you'll note, again, 15% of those are score 3, those severity score 3 where the whole cow is sick. That's the red bars. Even if we break this down by pathogen or bug type, the baddies like E. coli and Klebsiella, still not more than 30% of those cases are systemically ill with a severity score of 3. All right? If we get in here to the streps and the coagulase negative staph and the Staph aureus, then we're only looking, at a few percent, maybe 10, 15%. And across the board, not many cases are severe. Most of them are mild. So perhaps that is just Wisconsin. So here's some data from New York. These are 6 dairies where we have really good data from 2015 where we did a clinical trial. Average size dairies of about 1,000 cows here. So 716 clinical mastitis cases. And again, you'll note that very few of them have this clinical score of 3 where the whole cow is sick. Those ones that should be treated immediately and with systemic fluids and perhaps even antibiotics. The vast majority of them, again, approximately 85% of them, don't need systemic antibiotics and don't need to be treated immediately. We can wait 24 to 36, even 48 hours to find out what bacteria is associated with that clinical case, and then make a more prudent drug choice. So here it is, judicious antibiotic use. Do not administer antibiotics to cows that will not benefit. All right, so we can look through 690 cases here. Chronic Staph aureus cows, probably not going to benefit from another round of tubes. Mycoplasma, never benefits from any tubes. Multiple infected quarters, probably a losing battle. Damaged teats, they probably need some physical therapy, not antibiotic therapy. Those cows that have serious metabolic disease in addition to mastitis, probably not going to respond really well. Repeated previous treatment failures. So if this is her third or fourth case of mastitis with lactation and she's had already 15 tubes, probably another few tubes is not going to make a difference. The same thing with those that have a history of chronically high somatic cell count. So let's look at this by bug. All right. If there are no growth or no bacteria, then there's nothing there to kill with antibiotics, so they shouldn't get treatment. I'm going to suggest these grade 1 and 2, the severity score 1 and 2 E. coli, they're not going to benefit from treatment either. Neither is Enterobacter, yeast, Staph aureus, Enterococcus, Trupperella pyogenes, and other gram-negatives. As we mentioned, these grade 3 E. coli, they should get systemic treatment immediately. Environmental streptococci, like strep uberis, strep discalactia, they should be treated. Perhaps Klebsiella could be treated, but that's debatable. Coagulase negatives may be treatable, again debatable. So even if we look at this slice of the pie right here, these few slices, not a lot of cows that are likely going to benefit from treatment. So here's back to those New York herds closer to home. And one thing we'll notice here, that we'll look at some data from other herds too, about a third of the clinical mastitis cases, we get no growth of bacteria under standard aerobic conditions. And if there's no bacteria there, I'm going to suggest that there are anything for antibiotics to kill. So we're probably wasting time, money, milk withholding, risk of antimicrobial residues, and antimicrobial resistance by putting tubes in those cows. And sometimes we get about a quarter, 20% to a quarter of the cases are strep, 15% E. coli, some Staph aureus is still around, and then a smattering of other things. So why don't 20 to 35% of these cows have any bugs when we try to grow it here in our lab, which is pretty good, or if you even try to grow them on farm? Why no bugs? One thing to take away from this, if you learn nothing else today, is that mastitis detection, when we see clots, flakes, gargot in milk, that's a result of an immune response, not the active infection. The active infection could have happened sometime 12 hours ago, 24 hours ago, a week ago. We don't really know when the bacteria actually crawled up through the teat sphincter into that teat and colonized that secretory epithelium. Right? Clinical signs are inflammation, not infection. A lot of times, the cow's immune system will have already gotten rid of all that bacteria, or that infection happened a long time and we're just seeing resulting inflammation. If there aren't any bacteria there, there's nothing to kill with antibiotics. So if you're collecting milk samples cleanly, right, at least 20% of the samples should be culture negative. If something grows from all of your milk samples, sampling was not correct, and you're doing something silly like putting all 4 quarters into one tube, or you're not collecting them cleanly. Unfortunately, we can't come up with a standard protocol for all farms that say, okay, we're going to treat all cases that look like this with tube X, in all cases it looked like that with tube Y, and the cases it looked like another with nothing, because each farm has its own ecology, its own ecosystem of bugs on it. So here's data from 4 different New York State dairy farms. And if we look, about the only consistent thing across these 4 relatively large farms is that we're at about 20 to 33% no growth. That's pretty consistent across all of these farms. All right? And that's probably a good thing, because it means we don't have to put tubes in those cows. However, this dairy has a lot of Klebsiella. This dairy has a lot of Klebsiella. These 2 dairies have very little Klebsiella. This dairy doesn't have much E. coli. These 3 dairies have lots of E. coli. This dairy has lots of Strep discalactia. This dairy has relatively little Strep discalactia. So as you can see, there are some similarities, but more differences among these herds. So how do we figure out which cows to treat and what to treat with? Well, Frank Welcome says, one thing we can do is guess and let God sort it out, i.e. no culture. And back when I was a baby vet in the mid-90s, I just graduated, I thought I had some pretty superhuman powers, and by sniffing the milk or looking at the milk or seeing how gooey it was, maybe even tasting it, right, I could figure out what kind of bug was in there. And 20 years later, I've actually lost those powers which I once had. So I don't know how to do that anymore. So no culture is a common thing to do. You could do it yourself on the farm. And we'll talk through this a little bit. This is a good thing to do and will help us figure out which cows to treat and what to treat with. Or you can send the milk into somebody else, a reference lab. There are a lot of veterinary clinics which have really good labs, and QMPS is a pretty good lab as well. So the most commonly used method across the dairy farms for those 9 million cows lactating in the United States today is guess and let God sort it out. And what this leads to could be treating all of them, and that leads to over-treating. Hopefully by now I've already convinced you that we don't need to put tubes in every cow with mastitis, and we're going to go through some data at the end of this presentation, which is done right here in New York and shows us some local results. You could treat none, and back in the early 90s, this was pretty much in style. We could, it was recommended to give the cows some oxytocin, perhaps some aspirin, and strip them out frequently and not use any antibiotics, and that led to under-treating cows. We ended up with lots and lots of chronic strep infections which otherwise should have been treated. And as I mentioned already, treat based on some subjective criteria, which was my favorite method 20 years ago. And this is admittedly haphazard. It leads to over-treating some cases, not treating others, under-treating some. There's a perceived low cost to this method and no delay, and that's why I think it is widely employed. But hopefully by the end of this presentation, I will be able to show you that this perceived low or no cost actually ends up costing our dairies money. On-farm culturing. Good thing to do, and we can help dairy farms set this up if they want to do it. Timely decision making for treatment or not is about what we should try to emphasize here. And if we cleanly, again, I can't emphasize enough how important it is to take a aseptic clean sample, all right, plate that out, and in 24 hours we can get results that at least tell us there was something growing there or something not, growth and no growth. We can also decide pretty reliably, probably 80 to 90% of the time, whether it's a gram-positive or a gram-negative organism. Where people get in trouble with on-farm culturing is when they start to pretend they're microbiologists and want to figure out if they've got prototheca and yeast and Strep discalactia versus Strep uberis and maybe even plus or minus Staph aureus. Selective media is something that can help with on-farm culture. And here's just one of the examples that you can buy in the marketplace here. This is the Easy Culture system, or the Minnesota triplates, and it's got 3 different kinds of agar on one plate. And over here it's got McConkey media, which only grows gram-negatives. And over here it's got this NTKT, which only grows streptococcus. And down here it's got this factor media, which grows all gram-positives, so staph and streps. And these plates cost about $3 each. And then if you put a little bit of labor in there, some supplies, which includes culture vials, some swabs, some equipment, which is a pretty bare bones incubator, and some time to get a bunch of people trained up to do this well, you're probably looking at $5 to $6 a culture. And if you run through this algorithm with those plates, you can figure out if you've got growth, no growth, gram-negative, or gram-positive pretty darn well. So you look at this and you go, okay, did anything grow after 24 to 36 hours? There's no growth. Then you can work with your veterinarian and come up with a plan for what to do with those no growth. I'm going to suggest if it's those grade 1 or 2 severity mastitis, probably they don't need to be treated. If something grew on the plates, then you go, okay, hey, did it grow on the factor media or did it grow on the McConkey? And if it grew on the McConkey, it's a gram-negative. And again, for those grade 1 and 2s, if it's a gram-negative, the data shows you probably don't need to treat them. If it grew on the factor media, then you got a gram-positive, and then you can start to decide, okay, did it grow on the factor only with a zona hemolysis? Probably Staph aureus, right? Was it growth only on the factor with no zona hemolysis? Probably some other staph. If it grew on the factor and the NTKT, probably a strep, and these guys should certainly be treated, okay? I'm going to suggest if you're a dairy with a 1 strike and you're out rule for Staph aureus, i.e. you're culling all your Staph aureus cows, I would probably get that confirmed by a reference laboratory because culling cows unnecessarily can be pretty costly. So, on-farm culturing. Upside of doing that, a reference lab is too far away, and you just want to do it yourself. Downsides, mycoplasma under standard conditions cannot be detected with standard conditions, okay? Prototheca is a little difficult to do. As I mentioned, Staph aureus false positive risk, probably about a 15–20% false positive risk there. So you want to make sure you get those confirmed. Protocol drift, as we know on the dairies, any protocol we put in place has opportunity for drifting. You've got to maintain a little bit of equipment and inventory to do this. And then there's the opportunity cost of valuable people's time. And I estimate for about 1,000 cow dairy, you're going to need to train probably 3 people do this well if you want to carry this out 360 days a year to account for 7 days a week, the time people are off, holidays, sickness, whatever. You're going to need 3 people who are pretty good at this to get this done well on farm. If you do decide to do on-farm culture, I think it's probably a good idea to get some lab proficiency support. And Quality Milk, we have a little system set up for external quality assurance. And one, we can train you how to do this on-farm culture. And then quarterly, we also send you unknown samples that you'll plate out and see if you get the right answer. We review those results, and we work with additional training if you need it. So how about you've moved beyond guessing and letting God sort it out. You don't want to be burdened with setting up a microbiology lab on your own dairy. If you're close enough to a reference lab, that might be a good thing to do. You can work with a vet clinic who does this, or a lab like QMPS, or depending on what state you're in, maybe some other state diagnostic lab. Upsides to using a reference lab is you have experts doing the work. The microbiologists who do this, they do it all day, most of every day. Okay? All pathogens, including Mycoplasma, Prototheca, Listeria, etc., We can identify those. We have quality control. It's daily. We got a guy who's actually kind of a pain, and he makes sure we dot all the I's and cross all the T's. The dairy doesn't have to worry about incubators breaking down or keeping inventory of some supplies. And the only training that needs to be done on the dairy then is to take clean samples. But I can't emphasize this enough. If we don't take clean samples, altering milk is useless. And for New York State dairy farmers, this costs $5.50. The downside of the reference lab is perhaps it's too far away to get samples to the lab. But we have QMPS here, courier services, and we'll drive 45 minutes to an hour in just about any direction to pick up the milk samples 360 days a year to help you guys out. So this is how it works here with our 24-hour, 7-day per week service. A cow gets mastitis. The milk sample is taken cleanly on the farm. I can't emphasize that enough. The events are entered into the computer. We've worked really hard with the folks at Valley Ag Software to get this all synced up with DairyComp. And if you elect to do this, we can spend a lot of detail on how to get this to work in DairyComp. Then the courier picks up the samples. We accession them here at the lab, and we report back the pathogen ID to you 24 hours after we pick up the sample. And then for some dairies, they've elected to have a protocol-driven treatment, automatic treatment assignment in DairyComp 305. So here's how these words work, right? We have the event of mastitis, and we take a clean sample here. And you can tell, right? Gloves, squirting it into a sterile vial. And this event is entered into DairyComp 305. And doing this electronically, the cow ID is only ever entered once at the farm. That's the way we have no mess-ups on cow ID. That data in DairyComp is put on a USB stick, and then our courier here, blowing dust, comes and picks up that USB stick with the data and the milk samples. All that's back here to the lab where we accession it. In quality milk, microbiology magic happens, and 24 hours later, this data is pushed out to Valley Ag Software iLoop. It gets back into DairyComp 305, and if you choose to do it, you can auto-assign the treatment protocol based on the pathogen, and we'll end up with a no treat or treat with whatever you and your veterinarian have come up with. We can follow this right in DairyComp. So at this particular dairy, all right, 6893 had a mastitis event here on 122, and when it's in the computer and awaiting to get to the lab, it says Lab A, awaiting, and this happened in your right front. When the sample gets to the lab, when we accession it, this changes in DairyComp from Lab A to L. 24 hours later, turns out she had an N, no growth, so she had no growth. Every day, 24 hours later, the veterinarian of record and the QMPS personnel and whoever else on the dairy wants it can get this mastitis compliance monitor. And for this particular dairy, okay, they had 11 mastitis events the previous day. Results ending up here, this is uterus, right? We have some other pathogens, Klebsiella, et cetera, and then the protocols which they got on. And here's an example from one of the dairies that is doing this. This is the flow chart built up by the veterinarian of record on the dairy. So a cow gets clinical mastitis, or perhaps a high somatic cell cow, right? If she has no history of mastitis in the past 14 days, we culture that affected quarter. If she has mastitis in the past 14 days, she gets moved over to pen 1 and we watch her. If she's cultured, okay, she gets moved into pen 10, treat systemically if she's one of those grade 3 cows, and then we're waiting 24 hours to get the answer back. If it's an A, R, M, or H, check the meat withholding date and cull the cow as soon as possible. So this would be a strep ag cow, or a strep aureus cow, or a mycoplasma cow, or a prototheca cow, right? Don't ask me how dairy comes up with the letters for these. If it was a culture result S, or strep, or coagulase negative staph, or a group G strep, or strep discalacti, or strep uberis, right? Treat on this particular dairy with 1 tube of Hedison in the affected quarter once daily for 3 days. All other culture results keep in the hospital pen until mastitis is clinically normal. Pretty simple stuff. And that all gets into dairy comp and is driven by the pathogen result. And remember, I started off with this slide here. Okay? There aren't too many choices for treating cows with clinical mastitis. So that shouldn't be our main point of decision making, because most of these drugs are about the same, and there's been some trials done that show, right, that this one is not that much different than this one, and this one is not much different than that one. Okay? The main difference, I think, should be how many times a day you want to work on mastitis cows, because some of them have labels to treat 12 hours apart, like Amoxicillin, Cephalac, and today, dairy clots, or if you want to treat once a day, Hedison K, Spectrum-Ass, and Pursue. And I think those are the biggest differences if you want to treat once a day or twice a day. And as dairies get bigger, most of the big dairies are using once a day hospital chemical.
Daryl, could I just interrupt for a second? This is Kathy. Could you go back just a couple of slides to the culture protocol that the one dairy was using?
Yep, this one.
Yeah. So on on the box it says culture affected quarter in clinical cow culture CMT. Do you know where I'm looking at? Okay. It says right there that they're going to start treating before they get the results back from the culture. That sounds like it's sort of not what you were recommending earlier on. Should they be treating before they even get the culture results back?
That's a good question there, Kathy. No, they shouldn't treat before they get their culture results back, but I'm also looking to see where it says to treat before they get the culture results back.
So it says here, at the place cow in pen 10 and await culture result, treat systematically as needed. So reading that as they started treatment there.
Okay.
No?
So it says place cow in pen 10 and await culture results. Probably say before treating there. And this says treat systemically.
Uh-huh.
Okay.
Yeah.
Not systematically, but systemically as needed. So for those cows which have that clinical score 3, that 15% of really sick cows, okay, they should be treated systemically. Okay, that will be fluids, perhaps intramuscular antibiotics, but not putting anything in the udder until after we get the culture results back.
Okay, and so then that sort of leads to my next question. Earlier on you said that 85% of the animals won't have a different outcome if you wait to treat for 24 to 36 hours?
Yep.
So during that period, that when you've identified a cow that has mastitis or appears to and has somatic or has a somatic cell issue, so do you start treating systemically then during that 24 while you're waiting that 24 to 36 hours?
For which cows?
For the cows with that, you said that 85% of them won't have a different outcome if you wait 24 to 36 hours.
Of cows will not benefit from systemic treatment.
So you should just not do anything for them until a day and a half.
Correct. Yeah.
Okay.
For 5% of the cows, just put them in the hospital pen because they're not systemically ill.
Okay.
Okay. Wait for the culture result, and if it comes back with a treatable organism, then we can treat 24 to 36 hours later. Okay.
Mm-hmm.
If it comes back with an untreatable organism or no organism, then we just wait for the milk to get better, and on we go.
Okay.
Does that help clarify? That's
Yep.
a great question, Kathy.
And so then I actually just have one more. So on the other side, it says history of mastitis within the past 14 days, move to Pen 1 and monitor. So when they're monitoring, are they treating systemically? Are they looking at culturing those cows? What are they doing with those animals over there if they start to see something?
So these cows are unlikely cured from their original event.
Okay.
Right. So we'll monitor them to see if they get sicker and need systemic treatment. Again, most of them won't. Most of the time that abnormal milk will clear by itself if they've been treated appropriately or not here.
Mm-hmm.
Does that answer your question there?
Yeah, that's fine. Yep, thanks, Daryl.
Perfect. Those are great questions, Kathy. I'm sure anyone else who is listening probably had those questions also, because I'm just yammering away here, blazing through this stuff. Any other questions, anybody? Good. I'm glad you're listening, Kathy. All right. So quick detour into technology here. One thing that helps us at QMPS do this stuff really accurately and really fast is we have a new gizmo called a Mastitis, and some people call it our laser, okay? And this is what it looks like. And in minutes, for just a few dollars, we can be 99% accurate with this matrix-assisted laser desorption ionization time of flight guide. So the way this works is cow gets mastitis, we grow it up on the plate for a little while, then we pick a colony off it and put it onto this target plate or matrix, stick it into our big laser, and then bioinformatics based on the protein sequences of that bacteria allow us to do this very accurately, very cheaply, and very rapidly. So I just want you all to know, and because you're going to be hearing more and more about this Mastitis or laser that is out there for bacterial identification. And this really helps us do a snazzy job in mastitis identification. All right. So this is the part that probably everybody's been waiting for. Everything else has been introduction and theory. Hey, how does this really work on a real dairy farm? So we put all this stuff through the test out on a local dairy here just up the road. And since then, we, in the last few months, we have now 6 farms that are on our 24/7 full service. A few more where we pick up 7 days a week, and more than 20 farms here in Central New York that are on our courier route. So the objective of this study was, does waiting for about 24 hours for pathogen ID, as I've described, and then only treating streps and coagulase negative staphs with 2 tubes of today, and we're going to call that PB, pathogen based, versus treating immediately with 5 days of Spectromass, and we're going to call that BT, blanket therapy. And the reason we went into this is this dairy up the road was sending us lots of milk samples, but they were also treating immediately with 5 days of Spectromass. And I said, hey guys, I bet we can help you out and do better. We can cut your drug costs, we'll probably decrease your hospital pen density, and we're going to allow you more saleable milk if you spend a little bit of money up front figuring out what pathogens are there. So we put this to the test. So big dairy up the road here, and as I mentioned, we turn the results around 24 to 36 hours after identifying the mastitis. This dairy has really good electronic data transmission and other good computer records, and we also have access to DHI information there. So this is how the study was set up. All the cows on the dairy were randomized to one of 2 treatment groups in dairy comp, and just were waiting for them to get mastitis. So every time a cow got mastitis, the guys would go over and look in dairy comp and say, okay, was she in treatment group 1 or was she in treatment group 2? All the cows had a milk sample taken, okay? If she was in treatment group 1 and had mild or moderate mastitis, they would wait, okay? Oh, sorry, if she was in 1, they would treat immediately with 5 days of Spectramax. If she was in group 2, we would wait to treat until we found out what the pathogen was, okay? And we treated the Strep's Colitis negative staph with today. And in both groups, if the result came back as Mycoplasma, Staph aureus, or Prototheca, they were culled, okay? And any of those cows, like I said, with clinical score 3 were given systemic therapy. In this case, it was XNL and hypertonic saline, and not included in the analysis. So here it is in a little bit of a flow chart, if this helps. So there was a clinical mastitis event. If she had severe systemic signs, she was not included in the trial. And I'll let you know now that that turned out to be, I think it was 15 or 16% of the cows, like every other dairy. If she had, like 85% of the cows across the country, mild or moderate signs, right, she got assigned to either the blanket therapy group or the pathogen-based treatment group. If she was assigned to the pathogen-based group, we waited 24 hours before we treated her, okay? And if she had staph species, strep species, enterococcus, she got cefaclorin sodium, which is today. If there were staph aureus, Mycoplasma, Prototheca, strep bag, cull immediately. No treatment on anything else. In the blanket therapy, okay, everybody was treated for 5 days immediately, except for staph aureus, Prototheca, strep bag, those were culled. So we compared success as next test day linear score as a marker of what this did to somatic cell count, next test day milk production, duration of the clinical signs of mastitis, risk of being sold or dead at 30 and then again 60 days after the mastitis event, and we compared the total time out of the tank. We also looked at the risk of being a chronic E. coli, comparing those cows that got treated with Spectramax immediately versus those that didn't get treated to see if that E. coli persisted. So we looked at 725 clinical cases, of which 16% had that clinical score 3 and were not included in the trial. 37 cows were culled and excluded because they had staph aureus or mycoplasma, and 85 others were excluded because they had multiple diseases or protocol errors or something like that. So we ended up with 246 cases in the pathogen-based group, okay? Again, where we waited for 24 to 36 hours and then put 2 tubes of today in them. And we had 243 in the blanket therapy group, again, where they got treated immediately for 5 days with Spectramax. All right. So in the pathogen-based group, we had about a quarter no growth and about 20% no growth in the blanket therapy group. No significant organisms were about the same. A couple % each of coagulase negative staphs, about 30% streptococcal species, and about a third gram negatives, and a smattering of a few other things. So, did waiting for 24 hours for pathogen ID and then treating only streps and staphs with today 2 times versus treating immediately with 5 days of Spectramax change the length of clinical mastitis signs? The answer is no. It was 4.5 days in the pathogen-based group and 4.8 days in the Spectramax group. And I'm sure you'll all agree you can't tell a 0.3 of a day in that. Another interesting thing to remember here is that we treat or don't treat. If we treat some with today and not treat others versus treating everything with the most expensive tube, the amount of time that the mastitis occurs or the milk looks abnormal is between 4 and 5 days. We've done this multiple times. What that also means is that on day 2 or 3, if the milk isn't looking better, don't change tubes. Stay on the protocol because it takes 4 or 5 days for the milk to go back to normal no matter what you do. Just waiting 24 hours for pathogen ID and treating only streps and staphs with today versus treating immediately with spectrum as change linear score at next test day. Punchline is no, virtually the same. 4.3 in the pathogen-based group and 4.4 in the blanket therapy group. So far, hasn't changed length of clinical signs or somatic cell count. Does it change milk production? Again, milk production at next test day, not different between the groups. 76-ish pounds in the pathogen-based group and 74, 75 pounds in the spectrum master blanket therapy group. Does it change the risk of being sold or being dead 30 days after the mastitis event? Nope. Okay. 3.7% in the pathogen-based group and 5.8%, okay, in the blanket therapy group. Not statistically different, even though the pathogen-based group was a little lower. How about 60 days later? 9.3% in the pathogen-based group, 11% in the blanket therapy group. Not statistically different, again, even though the pathogen-based group is numerically better. So these are sort of boring results. Did anything change? One thing that did change is the number of days that the cow is out of the bulk tank. Turns out we had 3 more days of saleable milk in the pathogen-based group compared to the blanket therapy group. So days out of the tank, 5.8 in the today group and 8.8 in the spectrum mass group. Did it change the risk of chronic E. coli between the groups? Nope. Neither group had any cows that cultured E. coli 14 and then 21 days again after originally being culture positive for E. coli when they had their mastitis event. So what does this do economics on the dairy? Because we've got to add in, okay, cost of culture, right? And we put this in here. All right. So here's the blanket therapy group. Here's the culture-based group. The assumptions in this economic model we made that we're going to pay people working in the hospital pen on average $15 an hour. 1 tube of spectrum mass is going to cost us $3.80. A tube of today, $3.10. We built this when milk was 20 bucks a hundredweight. It's not anymore, unfortunately, but we'll do some sensitivity analysis on this. Mastitic cows making 60 pounds a day, and at this dairy, they were running about 5% clinical incidence per month. Okay, and then the culture-based group, intermammary therapy was 35% got treated and 65% didn't. Remember, it was 100% treatment for those in the blanket therapy group. So total antibiotic cost here, $19 for the blanket therapy group, and then $6.20 per case for the culture group. Labor costs a little bit more here because we had to treat them more often. Culture costs, no culture costs though, right, here in blanket therapy, but we put in $6 for culture for the culture-based group. Then we have lost milk income from days of non-saleable milk. Remember, it was 8.8 here and 5.8 for these. Total lost milk, 528 versus 348, so lost income there, $105 versus about $70. Direct cost per case, $132 versus the average of 85 and 76, and we take this 35% and 65% here. So if we put that all out over a year per 1,000 cows, we're looking at about $79,000 here, $47,000 here, for a difference of about $31,000 upside for spending the $6, okay, and getting the culture results. So per 1,000 cows, $30,000 upside, or $30 a cow. How about we change the monthly incidence to 2%? Remember, back here we were at 5%, but let's say we do all kinds of smart things and we decrease mastitis monthly incidence to 2%, which I will assure you is a very good thing. This program still pays upside of $12,000 per 1,000 cows, but it also shows the great impact of preventing clinical mastitis cases. There's no doubt we spent the last 45 minutes here talking about what to do when we get a clinical case. Prevention is still the most important thing. The next thing somebody usually asks here, well, I need antibiotic-laden pus-filled milk to feed my calves. Okay, so I'm going to value that milk at 0. Okay, so we're going to value that milk at 0. Does this still pay? Yeah, even if we say we're going to discard all this milk, we're going to feed it to calves, we're still upside $9,000, almost $10,000 per 1,000 cows, even if we feed it all to calves. So, in summary here, this economic comparison of immediate blanket therapy versus delaying and using a pathogen-based treatment protocol for clinical mastitis in a New York dairy herd. Okay. If we do this, we reduce treatment costs, increase the volume of saleable milk, and allowed for a 67% reduction in intramammary antimicrobial use, which grandmothers, aunts, and uncles all over the world think is a good thing, with no impact on the therapeutic success, resulting in an increase in cash flow of over $30,000 per 1,000 cows. Okay. I think there's lots of work out there to get with your local veterinarian to devise appropriate treatment protocols for your dairy, because you can save money on tubes and labor, you can decrease the risk of residues in the tank, you can mitigate the risk of antimicrobial resistance, have better hospital pen management, right? If they're in there on average 3 less days, you're going to have lower hospital pen density, and ultimately you're going to be able to sell more milk. So I think that's about where I'm going to end. Maybe there's some questions, at least questions from Kathy. Anyone still there?
Yep, we're still here. Daryl, actually, I do have a question. So this is really eye-opening information here, especially you know, when you get down to the cost factors there. I want to know, do you have a feel for how many of our dairy farmers are now routinely using a pathogen-based treatment protocol?
I would say our farmers, and I'll say that even nationally, it's in the single digits. Right?
Okay, so well, there's really an opportunity here. Really an opportunity.
Huge opportunity for the dairy industry to make more money and get on side with consumers. Right? It's hard to open up any newspaper or news magazine and not hear some guff about over antibiotic use. Right? Yeah. And this, it doesn't hurt the cows. It helps the bank account of the farm. And it gets us on side with consumers. So I think there's a large opportunity here. Yeah, absolutely. Okay, so it looks like there aren't any other questions, Daryl. So with that, I'm just going to thank you for an excellent presentation. Very worthwhile. Thanks, folks, for joining us. Oh, we did get a comment. Great information. Thank you for Melanie. So anyway, we'll kind of wind up here. I'll remind you, folks, that next Thursday from 1 to 2, we'll have Dr. Tom Overton talking about some where he sees transition cow nutrition heading in the next year or two. So as far as research and that sort of thing. So another excellent presentation. So with that, Daryl, we'll sign off and thank you again, and hope to have some of our folks join us next week as well. Thanks very much, folks. Thanks, everybody. Let me know if you got questions sometime.
Yep. Okay.